I want to briefly introduce Dr. Martin Lustick. He's a medical physician with training from Columbia University. He attended Cornell as an undergrad. He practiced for 17 years as a pediatrician in the Kaiser Permanente healthcare system. Subsequent to that, Dr. Lustick worked as a chief operating officer for an 800-member physician organization, and ultimately was the chief medical officer for Excellus Blue Cross Blue Shield health plan, which was quite a large health plan. He lives currently in upstate New York and has recently written a book, Health Plans Unmasked, a physician's guide to working with health insurers, which we're going to get into, I'm sure, in some detail. So with that, welcome, Marty, and we're really pleased to have you with us today.
Thanks, John. It's great to be here, and I'm glad we have a little time to talk.
Yeah, and as David suggested, please raise your hand if you have a question as we get into the topics, and he'll unmute you and we'll let you ask the questions, because I want to make sure we cover those points that are really of interest and concern to each of the people listening. So let's start just generally, and you don't have to go into too much detail here, but you functioned as a clinician, you functioned as an administrator for a physician organization, and you've functioned as the chief medical officer of a fairly large health insurance plan. And of note, your work as a clinician was with this managed care model Kaiser Permanente has. So based on that, what's the main thing you could tell us that those three perspectives have really given you through your career?
Yeah. Thanks for the question. I just point out that in addition to practicing and being in a physician leader role within a large multi-specialty group practice, I also spent a couple of years as the chief medical officer at the hospital in the town where I live now in upstate New York. The small hospital system before I went to Excellus. So I've had experience with being within the organizations that, from my point of view, are like the major stakeholders in healthcare, aside from the patients, which we all are at one time or another. You have the providers, the physicians and other professional providers, the hospitals, and the payers. And having had the opportunity to be in all three of those environments, I think it gives me a somewhat unique perspective on the issues that healthcare faces. I would say, as someone who's been part of healthcare for my whole career, it's somewhat embarrassing to be part of healthcare because we're all so highly trained. There's a lot of money in healthcare, and yet we're part of a system that does not serve the population well, at least from my perspective. And I come from a family that's somewhat of a long line of physicians, and so it's embarrassing to me that the system actually, I think, is more dysfunctional today than it was when I started 40 years ago, and that's not something to be proud of. And I think everyone in it, all the stakeholders, bear responsibility for the situation we're in now, and somehow we have to figure out how to all come together to get to a better place.
Yeah, absolutely. But it's wonderful that you can bring that perspective, because and I'm so grateful to you for having written this book, and I pray that the right people read it. Because if you can influence any measure of change, you're absolutely right. It could have a tremendous impact ultimately for the patients who we all are ultimately here to serve. So let's talk a little bit about your book. Actually, let's talk a lot about your book and get into that idea of what's behind the curtain, like the Wizard of Oz, with health insurance plans. David Payton, who you met, who's running the program for us, David is from South Africa. And I don't know if you're aware, they refer to their health insurance plans in South Africa as health schemes, which would go over well. And they don't mean that in a derogatory sense. That's the language that they've utilized. But I always laughed a little bit when I heard that and said, gosh, that wouldn't fly in the US. People may think that, but I don't think we're going to use that language. So one of the topics I know you delve into in your book is the shift from fee-for-service healthcare to these new, rather complicated value-based care systems. But my experience, and tell me if I'm wrong, has been that transition is exceedingly slow. Michael Porter, in his Harvard Business Review article, said everybody's vying to be the last iceberg to melt. Everybody says, wait for everyone else to do it, and then I'll jump on board. What's been your experience in that shift from rewarding value to our current model of fee for service?
Yeah, I think you're right. It has been slow and difficult, and I think there's several key reasons why that's the case. From the health insurer's point of view, health insurance companies are financially they're risk averse. That's what insurance is about, avoiding risk uh,
Mhm.
or managing risk. And
Yeah.
so throughout the history of any insurance company, one of their top priorities is how to minimize risk. And change, from their point of view, by definition, is risky.
Mhm.
So they have all this investment in the systems that process claims and pay claims the way they do. So from an infrastructure perspective, they're well organized to pay claims, but not well organized to put in innovative payment schemes.
Mhm.
Um, the big, from my perspective, the biggest problem on the provider side is that providers, and particularly in the specialty departments, but in general, hospitals and professional providers have, from a financial point of view, the more they do, the more money they make. The focus is all, from a financial point of view, is how do I maximize my revenue so I can maximize my profitability? And the concept of value-based care is how do I provide the most value for the least dollars in order to
Yeah.
maximize my profitability? That's a completely different business model. So you
Yeah.
get these huge health systems that have been, whose entire business model, for example, in the hospitals, is keeping the hospital full and fully using all the very expensive capital infrastructure that they own and maintain. If they don't keep their volume up, they can go in the red very quickly. So how do you support a large organization that's dependent on volume in transitioning towards a value-based business model? It's a huge transition. And from my perspective, in order for it to work, the health plans are where all the money's coming from. So the health plans have to build transition plans with these large providers to help them manage their bottom line as they go through this transition. But
Mhm.
that's a risk for the health plans and it's a risk for the providers. And I would point my finger particularly at the subspecialists who, in the context of value-based arrangements, that the ones that have been built to date are largely focused on putting primary care doctors at risk, but not putting the specialists at risk. And that's where all
Oh,
the money is.
yeah.
Until specialists are paid based on value as opposed to volume, they're going to continue to do as many procedures as possible because that's where all the money is.
Yeah.
Um, there is a model where they can do as well or better focused on value, but it's a very different business model, and they would need a lot of support in making that transition.
Yeah. In healthcare, one of the things we've been aware of as chiropractors and physical therapists is this idea of third-party vendors carving out a service line. So we've seen it where they carve out chiropractic benefits, or they'll carve out of the plan physical therapy benefits, and then this third party will manage them. And I've seen that with chiropractic, physical therapy, eye care, and behavioral health, but I've never seen it with a medical specialty. Do they have that? Do they do it? I can't remember the name of the book. Shannon Brownlee, and I think it was called
Yeah.
Overtreated, talked a lot about invasive cardiology and putting in stents and how there was so much variation and what they felt was a lot of inappropriate use. But I've never seen a carve out for a service line like that.
Yeah.
Has that ever
Yeah.
happened?
So there have been attempts at it, but nothing has lasted. It's
Okay.
a good question. I've seen in the past attempts at doing it with cardiovascular disease, way back, this was probably in the 1990s, early 90s. There was a health plan that no longer exists that had a very interesting idea for specialists that they
Mm,
implemented. It lasted a couple years, which is they budgeted how much they were going to pay to each specialty.
yeah.
And they advertised it to the specialists within a geographic region. The more services those specialists provided in a quarter, the less they would get paid per service. And the fewer services they provided, the more they would get paid. But
Okay.
the amount they got paid was how many services they provided compared to all the other specialists within the same geography. The idea behind it was your incentive is really, you can't game that system because you don't know what anybody else is going to do. So you
Yeah.
should just do the most efficient and effective care for your patients is the way you'll maximize your profitability. And it
Mm,
actually worked pretty well, but of course there are winners and losers in that process. Uh,
mhm.
so people who see way more patients in a given time frame than their peers end up not making much more money because of they lower the price per visit. So it was
Yeah.
an interesting concept. I bring it up as just an example of innovation has been tried in other areas. It's been tried actually in vision, as you mentioned, including with ophthalmologists.
Oh,
Um,
I didn't know ophthalmologists were part of it. I knew optometrists were, but
Well, they tried it with everybody. Again, this was back in the 90s when there were these national vision service organizations that included ophthalmologists that was trying to put basically local ophthalmologists out of business if they weren't
oh,
part of this
okay.
organization. From my perspective, one of the main reasons that those failed is because the specialists involved have too much power.
Yeah, one of my favorite books of all time is on the name of the author, Paul Starr. I think it's Paul Starr, The Social Transformation of American Medicine. And he talks at length about the cultural authority that medicine has achieved, legitimacy and competency, and how much power that's given the medical profession. And something that a limited license profession like chiropractic or physical therapy desires. We really desire some of the cultural authority.
Mhm. Yeah, it's interesting if you look. I happen to have been a history major before I went to medical school, so I'm always looking to say, how did we get where we are? If you go back, the history of how different parts of healthcare became fractured from each other. Why is dentistry not part of
Yeah,
medicine? Uh,
yeah,
why is podiatry not? Why is the foot different than the
yeah,
hand?
the rest of
Uh,
you.
it's just bizarre when you look historically at how these different components the of people who provide healthcare services have evolved and why there are these significant gaps in the way they're operationally integrated or not, in the way they're reimbursed or not, in the way they're accepted by others. It's quite a patchwork when you look
Yeah,
at it.
I
If you
think,
were designing a healthcare system, you would never have created it this way.
yeah. You brought up prior to this webinar starting, you had made mention of the fact that within a health plan, you've seen silo-based thinking and functioning. And that seems to be a big problem within healthcare in general, is this idea of different people functioning within their own silo, but not really appreciating the downstream effects of what they're doing. And I would assume as a CMO, you must have dealt a lot with that particular issue.
Absolutely. And so there's a lot of things I could say about it. I think from my point of view, the most important part of that is that in the modern world, health plans are required to have a clinical team led by a chief medical officer.
Hmm.
And I think that the clinical people in the health plan, particularly the chief medical officer and the medical directors, they're really the only people in the health plan that really understand what happens in the exam room when a provider sits down with a patient. And builds that relationship, takes that history, does that exam. And it's really critical that those people within the health plan are the voice of the provider and the patient, even though
Yeah.
everybody who's even the CEO of the health plan has been a patient at some time.
Mhm.
They don't fully understand the implications of decisions they make based on the finances and the numbers and the other pressures that they're under as a business without having somebody in the room who actually has a deep understanding of what's really going on in a therapeutic relationship. And one of the things I look for in terms of is this a good health plan or not, is do the clinical people have a voice on the executive team of the plan?
Yeah.
Are they sitting at the table in the C-suite? Because they really need to be there.
Yeah, that's a great point. To change directions a little bit, there's something that was in Rochester, New York for years when I started practicing back in the early to mid 80s.
Hmm?
And it was community rated insurance, which Excellus Blue Cross Blue Shield was. I thought it was my impression was that it was a pretty novel program where the large employers, the hospitals, the health plan providers all got together and they based the premium of the insurance based on the community, which I think must have really benefited small businesses because a small business might, if you only have 50 employees and two of them have AIDS or something, and they're going to ruin your experience of your company. But if you're part of a community, now that's filtered through thousands of employees, but it went by the wayside. Why?
So it wasn't
Probably
unique
not
to,
an easy question to answer,
no,
but
it's a really important issue. It was not that the community rated was not unique to Rochester. In
oh,
fact, I mentioned that I was at Kaiser Permanente. When I started at Kaiser Permanente, wherever it was in the country, they only offered community rated policies. It was a Kaiser health plan policy that they would only offer community rated.
good for them.
The problem, the reason that it's gone by the wayside is that when at the same time that the HMO Act was passed in what 1973, I think, the rules were put in place that have held that allow large employers to be self-insured,
Hmm.
which means they can contract with a health plan like Excellus and pay them a monthly administrative fee, but whatever the medical expenses are, the employer actually just reimburses the health plan. The health plan
Hmm.
still cuts the checks to the providers, but the employer takes almost all of the insurance risk and just pays for all the claims.
Hmm.
And they are not held to the same standards that health plans are. So they're allowed to provide different benefit structures. They can do a lot of things that health plans are not allowed to do, which goes to a whole nother issue.
Hmm.
But what happens is if you're a large employer and you look at your employees you used Rochester as an example, and my employees, in my 1,000 employees, are younger and healthier than the Rochester population at large, then if I become self-insured, my costs are going to be lower than the premiums I would have had to pay to
Hmm.
be community rated. Well,
Okay.
once they allowed self-insurance, if you look at today's world where it's gone from the 1970s to today, 2/3 of commercially insured patients are now self-insured.
Wow.
What that's done is not only does it extract the healthy people that lowers their, but the only people left for community
Yeah.
rated are sick people, as you mentioned, small employers, so their premiums are, they have nobody to offset their costs, so their premiums are incredibly high. The only
Yeah.
way to fix that is by changing the laws.
Okay. Yeah.
The health
Yeah.
plans can't do it on their own. As
Okay.
long,
Yeah. It's not really not their decision to do that. It's
yeah,
the large
yes.
companies. I think
And
because
I think this self-insurance is part of the problem is of the underlying problem in healthcare because
yeah,
it undermines the whole concept of insurance is that you're supposed to spread the risk
share
across
the
the whole
risk.
community so
Yeah.
that the people who are unlucky enough to have the expensive diseases the costs are covered by the whole the cost of the whole population. Now,
Yeah.
Obamacare did improve the situation. They put in rules that said you can't parse the risk into 30 different categories. They
Okay.
limited it, and they limited the amount of variation you can have in your different rated groups, but it didn't solve the problem.
Okay. All right. Yeah, I think it was at the time Eastman Kodak was in their heyday back then, and they cooperated in that program. And I think that's what
They
drove it.
they didn't
Seamless.
just cooperate, they led it. And
Yeah. Oh, they were
George
pushing for
Eastman, yes, George Eastman was a huge innovator in healthcare. And Rochester, as a result of Eastman's legacy, Rochester has done a lot of innovative things in healthcare compared to the rest of the country.
it.
And I think even still to this day, despite all the problems, Rochester will, unlike almost any other community of its size or larger, has better quality measures and lower costs across all parts of the healthcare system, whether you look at Medicaid, Medicare, or commercial, than 90% of the rest of the country.
Yeah, to carry on that idea, I don't know, what would it be now, about 14 years ago or so, you were part of that innovation and you decided to hire a chiropractor as a medical director within Excellus. And I'm sure that had to be, I'm curious how it was dealt with when you said, okay, let's do this.
Yeah.
What were some of the
Well,
obstacles you faced, some of the
I was
changes?
fortunate in that my bosses at the time gave me the freedom to do what I thought made sense.
Okay.
And it was really because you and Brian had built that spine care program, and I had seen the results of it in Massachusetts and said, why shouldn't we be trying to do this in our own
Ah,
region?
yeah.
And Brian had worked as part of the Lifetime Medical Group and demonstrated further that you could have an impact locally with a program like this. And to me, the idea of providing more appropriate care at the first contact that patients have with the healthcare system and avoiding them having to move up the pyramid to the most specialized providers. That's a concept that in my 17 years at Kaiser, we looked at over and over again is how can we better manage things so that they get dealt with at the first contact and they don't have to funnel through the system to get managed. And to me, this was a proven model
Ah,
that improved outcomes, improved satisfaction of the patients, and would ultimately drive waste out of the system, not to mention drive risk out for the patients who wouldn't have to be exposed to much more risky procedures. To me, it was an obvious thing. Honestly, the biggest challenge is because no, I didn't have anybody who I could talk to in another health plan about how do you do this with a
yeah.
chiropractor. My feeling was in order for it to work, I needed to hire Brian as a medical director, just like any other medical director. I had medical directors who were osteopaths and MDs. Legally, he couldn't necessarily do the same activities that other medical directors did, but
Mhm.
in terms of title and status and the way we graded it for payment, all that, it was really important to me that it was a full medical director position because I knew that it had to be externally facing also, and that it was really important to try and build credibility within the traditional medical system to
Yeah.
accept this kind of an approach. So that was really the biggest challenge was how to position it for success. And
Oh, that's
fortunately,
great. And in
Brian made
fact,
it a lot
I
easier.
apologize for not mentioning it's Brian Justice for those who don't know who we're talking about. Brian, one of the founders of Spine Care Partners and Primary Spine Provider Network, has just recently retired from Excellus Blue Cross Blue Shield, but served for some 13 years as a medical director for most of that under Dr. Lustick. That brings up another point that I'd like to ask you about, and that's the idea, because I know you get into this, the idea of a collaborative between payers and providers, that there's some effort to build that collaborative. And even with when you were with Excellus, we started trying to develop a collaborative program for chiropractors and physical therapists with the payer, which we never really got to develop the program the way we had hoped to. We had a lot of wonderful meetings. How do you think the systems can overcome the challenges to developing that collaborative relationship? Because there's in some states there's litigation between payers and providers. Michigan, for
Yeah,
one, with chiropractors, and
yeah.
we helped to quell that quite a bit, we were told, with the program we brought into Michigan. But how do we overcome some of the obstacles to getting that collaborative relationship going?
Yeah, some of it, I think, are policy issues that you and I don't have any influence or control over. From my point of view, some health plans are easier to collaborate with than others. And I would argue that for-profit health plans should be outlawed. Um, that there are a lot of problems with for-profit health plans, but one of them is that it tends to put them in a much more antagonistic relationship with the providers.
Mhm.
When you've got such a short-term time horizon where you're looking at your quarterly profit margin. And to me, the best example is Centene, which is a publicly traded company that whose revenue all comes from our tax dollars because they're a Medicaid health plan, and
Oh,
that they are
and therefore,
delivering a profit to their investors on Wall Street that's coming out of the money that's supposed to be providing services to the
yeesh.
most vulnerable populations in the country. Uh, to me, that just shouldn't be legal. And I think it would enable better collaboration, and it might require some positive legislation to encourage the collaboration as well. But all
Yeah.
that said, I do think that there are still opportunities. Large providers, if you're a big enough provider that your absence would create a gap for the health plan, then you have leverage to get the health plan to collaborate with you.
Yeah.
Sometimes that means you need to form some sort of an IPA or whatever in order to have that kind of bargaining position. But there also are advantages to being small. If you're a really small provider and you have a really innovative idea, it's very low risk to the health plan to try something, to test an idea with you. And
Ah,
sometimes the best way to do it is if you can find, usually it's a clinical person in the health plan that might have an interest in your area of expertise, and say, I'd like to brainstorm with you about things that could be better in our area. And I can give you a kind of a silly example of something that I actually was unable to carry off at Excellus, but is the kind of idea that you want to be approached with, which was actually a dermatologist who came to me and said, it's an analogous problem to what you experience in chiropractic and physical therapy, that the patients who had psoriasis were coming in to get injections every month at $5,000 or $6,000 an injection, when the safest, best treatment for their psoriasis was to have a light machine at home and just do phototherapy.
yeah.
But in order to do phototherapy, they had to come in and get it 3 times a week for a month and pay their $25 or $35 copay every time they came in, not to mention the hassle of coming in to see if it worked for them before they could qualify for doing it at home. And the machines cost maybe $10,000 or $7,500 for a machine, which compared to the cost of the drugs is nothing, not to mention the
Yeah.
fact that they're much safer than taking the drugs. And some people who go on phototherapy for their psoriasis actually can end up having long-term remissions where they can go for years without any treatment, which is not the case with the drugs. So his argument to me was it's a better treatment. It's ultimately much less expensive, much less risky. Can't you just waive the copays or
Ah,
do a rent to buy so that people can immediately get the machines at home? And if it doesn't work, they just give them back. And if it does, they get to keep them. But the health plan will do rent to buy with them. I was unable to get that implemented, but it's a great
hmm.
idea. And you don't
Yeah.
have to be a large provider to justify trying something like that.
Yeah.
And mostly the people who are out there providing the services are the most likely to have good, innovative ideas about how they could do it better if only they were paid differently for it.
Yeah.
And in my time at Excellus, I supported a number of small pilots with one or two or just a few providers just to test out new ideas. Not all of them play out, but it's a good way to start a collaborative relationship with the health plan.
Oh, that's a great idea. Do you think that the difficulty with getting something like that implemented is just the risk aversive nature of health plans?
Yes. So and because we talked earlier a little bit how health plans are siloed, so you
Yeah.
get a clinical person who thinks this is a great idea, but the finance people are focused on something totally different, and the people who do the claims processing who would have to modify the claims system in order to accommodate a different payment for this little pilot. Everybody's got to have their little piece of it. It's not like I could just do it without anybody else's involvement. So you've got to
Okay.
get buy-in from the other parts of the organization whose priorities are in a totally different place, who don't
Yeah.
really understand necessarily what you're even trying to accomplish. So it is, you need a well-functioning health plan, and you need whoever the internal champion is at the health plan has to be able to navigate the internal bureaucracy and cut through the red tape to actually make something like that happen.
Hmm. How,
And if you want a lot of war stories on that, interview Brian Justice on this because he
okay.
spent his whole time at Excellus fighting those
Yeah.
kinds of battles. And hopefully I was able to help him win a few of them.
I think you did. Yeah. Do the actuaries actually drive a lot within a health plan in terms of they seem to love what's predictable and that the
Yes.
actuaries can help them with that. And that to me strikes me as one of the reasons they're so risk averse. If they get something that they don't have actuarial data on, they don't want to touch it.
That's certainly true. One of the chapters in my book is about how the health plan uses its data. And I think your question about the actuaries highlights this issue from providers' point of view. If you ever are in a position to have a conversation with somebody in the health plan about the finances or exactly what their payments to you are, what the total costs are, you tend to get a lot of different stories, and it makes you feel like they're just pulling the wool over your eyes. They're not really willing to tell you the truth. The problem is that there are at least four different silos within health plans that take the claims data and they use it differently. They categorize the different claims differently, so their numbers within the organization don't even match with each other. So even if one of them
Okay.
comes out and tries to tell you their version of the truth, it's going to clash with, so the actuaries are one, but then there's a operations finance department that's the one that actually pays the bills
Yeah.
every month. There's the clinical people who are looking at the finances to understand what's driving cost and what's the variability among the providers, where are there opportunities to reduce waste in the system. But everybody categorizes the numbers a little bit different from each other. So same, what should be the same number never comes out the same. And it makes the health plans look like they're either lying or don't know what they're
Oh,
doing, but it's actually just because they have all these silos. And the
yeah.
truth is, they're all trying to be accurate within their own world. It's just their worlds are separate from each
They're
other.
so different and yeah, not communicating. That's really fascinating. I want to make sure that anybody who's listening in right now, please feel free to just click the raised hand icon on the bottom of the screen and we'll let you ask a question. I want to make sure that you each have an opportunity to ask Dr. Lustick a question. Um, as you had mentioned earlier, the spine program, which Excellus is still operating, which we're very grateful for, has had a measure of success. And our focus has always been on the early contact providers for spine care, primary care physicians, chiropractors, and physical therapists. But we've met reluctance to adopt the model. When we've talked to multiple plans around the country, everybody, they often say, but we have our own culture, which seems to be common among Blue Cross Blue Shield plans. And we've met some resistance with getting engagement. We've had some conversations with a orthopedic surgical organization that's formed their own big MSO, which they're traveling around the country with, which seems to be more palatable. I know part of it is culture to the plans, more part of it's cultural authority that the orthopedic surgeons carry, but as you had mentioned earlier, those are the high cost items. I would think that a health plan would be very interested in managing at the front end, so you don't have to worry about the back end.
Yeah.
Um,
So the problem is, and I think you framed it really well. The problem is that the health plans, because they're so conservative, they are very reluctant to believe that providing more services with one provider is going to reduce services with another provider, even when you present them with the evidence.
yeah,
They don't necessarily believe the cause and effect, and their historical experience of the actuaries is that the more services you allow to be delivered, the more their costs go up.
uh,
And it's overcoming that bias. I would argue that it's got nothing to do with the culture of their providers. It's got to do with the bias within their own finance department in the insurance
yeah,
company. But to your point, my vision, my belief is that you need to get going back to the value-based contracts, you need to get the skin in the game for the provider organization that's executing that contract so that they really are financially ultimately incented to get the best outcomes at the lowest cost.
yeah,
Because once you do that, in my mind, it shouldn't be the health plan that building a relationship with the chiropractors. It should be the orthopedics department at the hospital system that owns them
yeah,
that's saying, if we include a primary spine care network, we can dramatically reduce the cost of spine care. With the same set of surgeons that we have today, we can manage a capitated contract with twice as large a population because our
yeah,
surgery per population is going to be decreased by all this care, all this expensive care that's avoided for a large proportion of people with orthopedic problems. We'll be just as busy. We'll make more money than ever. We just don't need twice as many surgeons as we grow our population because we're going to gradually reduce the need for surgeries. That's
yeah,
the model that ultimately is, I think, is going to work. That's what the Kaiser model is. That's how the Kaiser
yeah,
model works. That's I mentioned to you before we started the webinar today that if you could penetrate the walls of Kaiser, I think they would be very interested in this because as a globally capitated medical group, programs like primary spine care that can improve outcomes and reduce costs are exactly the kinds of things that enable the entire Permanente medical group to financially profit.
yeah. That's great. That's great. Let's see, there is a question that was typed in the recent years. Oh, someone did ask about this, and it's up to you whether, if you're comfortable talking about it. The recent assassination of the United Healthcare CEO. Certainly, that's not going to solve the problems
Right.
of healthcare. But I don't know that they've ever established that it was the fact that claim denial increased, I think, 20 some percent when the CEO who was assassinated took over, that
Yeah.
claim denial greatly increased.
Yeah.
Any comment you want to make about that?
So a couple. One is I encourage people to read. There's actually a ProPublica article about the vendors that health plans use to help them control costs. And I'm actually quoted in the article, but it's an interesting read on some of the things that are being done that shouldn't be allowed, as far as I'm
Yeah,
concerned. I think it's going to come out in a week or two, was interviewed by a reporter at the New York Magazine. They're about to publish an article on this very topic of in the aftermath of the shooting, what does it mean? And I'll tell you, the big points I made to this journalist when he called was one, healthcare is a mess. Uh, and everybody involved in healthcare is responsible for the mess that we're in, not just the
Yeah,
health plans.
right.
And you can't actually solve the problems in healthcare if you just look at the health plans and you don't look at the context in which they're operating. That said, from a policy point of view, one of the things I mentioned earlier today that I think is really important is legislation that would make for-profit health plans illegal.
Yeah.
I do think that's part of the problem. And obviously, United is one of the big for-profit health plans who
Mhm.
happen to own over 100,000 physicians in the country as well. So,
Mm.
from my perspective, there's a lot of risk associated with that to the quality of healthcare that we're going to have in the future. Another thing, though, that I think from a policy point of view, here's an example that's not a health plan issue. The fact that manufacturers, and particularly drug manufacturers, are able to essentially charge whatever they want for the
Yeah.
drugs that in there. It's new technology is by far the number one driver of costs. And sometimes that new technology is life-saving, like the COVID vaccine. But
Mhm.
lots of times it's not. It's not even barely better than what's already
Correct.
available. And so another recommendation that I have is for those that might not be familiar, there's an organization called ICER out in California. It's a private, not-for-profit institute run by a Dr. Stephen Pearson. And they evaluate drugs, new drugs or new uses for drugs, and they evaluate them based on the dollar value that they represent. How much better are they from a dollar perspective than current treatments?
Ah,
And if you establish ICER as an independent organization that the government recognized as a source of truth around the value of new technologies, then and the government allowed prices to be set based on how this independent, not-for-profit organization evaluates them, it would go a long ways towards controlling costs. The health plans have cannot do that. And all the other developed countries in the world do something along those lines already. It's part of the reason why their healthcare isn't as expensive as ours. So I bring it up because it's important to understand that it's not just fixing the health plans, and the
yeah.
financing is not the only problem that needs to be fixed here.
Yeah, absolutely. It's going to take a lot of input from a lot of different people and organizations. And it sounds legislatively, that's a big driver because of the allowance
Right,
for-profit health plans,
right.
which I
And,
don't
and
make no
I'm
sense to
not
me.
optimistic.
Yeah,
I'm not optimistic that anything important is going to happen at the national level anytime soon, but
sure.
states might be able to make some progress.
Yeah. When you have a fiduciary responsibility to your investors, and that money you're hoping to give to them is used to pay for healthcare, boy, there's a real conflict of interest. So
Yes.
yeah, I agree with you completely. I wish they would just outlaw for-profit health plans. And I want to be respectful of your time. We're right at the top of the hour now. Are there any additional questions anybody would like to ask? Please feel free to jump in to the conversation.
Yeah, Marty, this has been great. I find this fascinating anyway, the whole topic, and I liked your comment about everybody's responsible, including consumers.
I
Um,
agree.
but I wondered what your thoughts were on with our patchwork system and the fact that we dump everyone over 65 into Medicare. There's just no incentive for commercial payers, for example, to invest in preventive measures. And I just wondered how much of an impact you thought that had on the health outcomes for the
Right.
country.
I think that's a really, I'm glad you raised the issue because particularly I mentioned with for-profits, they're looking at their quarterly results. A lot of preventive care is looking years down the road at costs. And one of the challenges for the health plans is that if they invest in a hepatitis C treatment for a patient who's asymptomatic, the benefit of avoiding liver cancer 20 years down the road, that patient may or may not be their member at that point, some other health plan will benefit from the fact that they paid for it. It's part of the reason why you need to have regulation that forces coverage of preventive care. But the other issue here is an interesting one, especially in the United States, because I would argue that health plans that have market dominance in a geographic area, and I'll use Excellus as an example in the Rochester area, that they have such market dominance that from their point of view, everybody who lives in the area is either their member or going to be their member. And so they actually have more of an incentive because of that to invest in prevention than health plans that might have 10% of the population in a geographic area, but they have 10% all over the country. So they're huge health plans, but their penetration geographically is generally very small. So they have turnover in their membership. They have no interest in this.
Yeah,
Yeah, that makes sense. Yeah.
it truly does. Great. Unless anyone else wants to come up with any last minute questions. Marty, thank you so much. This has really been a wonderful discussion. And you can buy Marty's book on Amazon. I highly recommend you get it. It's Health Plans Unmasked. Let me get the correct title correct. Physicians.
I don't know how to make it so you can see it.
Yeah, there it is. Health Plans Unmasked, and it's Martin Lustick, Lustick, MD. Marty, thank you again so very much. And David did provide a link to the book on Amazon in the chat, if you want to click that on and go to it. And we're hoping we can also corral you into being interviewed on our podcast by Dr. Rebecca Deo. And we'll be in touch with you, and hopefully we can do that.
I'd be happy to, and thanks for having me today. It was a lot of fun.
Yeah, thank you again, Marty.